Welcome everyone to our last week, week 12, and we will discuss financial leadership and accountability and managing resources. Healthcare costs in Canada continue to rise at a rate greater than inflation. All nurses, but especially nurse leaders, must be aware of financial decisions within their units and organizations so that resources are used efficiently and equitably. So let's look at Canada or Canadian healthcare spending statistics. We spend about $264 billion on healthcare, and that's about $6,800 per person. There's been a 4.2% growth in healthcare due to inflation, and we use about 11.6% of our GDP. And so GDP is the gross domestic product, and it's the total monetary value of all the goods and services in Canada. And so it's kind of like you think about this is how much we have in our bank account. So you might not think that 11.6% is very high, but when you think of all the money that's used for the public sector funds, so this is money coming from the public sector, if a significant portion of the GDP is spent on healthcare, it poses problems to those other programs. So money becomes diverted away from social programs, from such things as childcare, housing, education, transportation, and the environment to support healthcare costs. So it's very important for nurses and nurse managers to understand this. Now, nurse leaders can't directly affect healthcare spending at the provincial and the national level, but they can think about the money that is spent within their units and organizations, and they can be financially aware as they make decisions so that resources are used both efficiently and effectively. So where is our money going with respect to healthcare? Well, the biggest areas that money is directed with healthcare is hospitals, prescription drugs, and physicians. Other than that, you need to think about labor costs for nurses and all the other interdisciplinary team members. Money that goes into the community setting, home care, health care, retirement homes that maybe have some funding from the healthcare system, long-term care homes, and things like that. So you can see here the most money are going to hospitals. And so that is something that you will hear time and time again about decreasing the money that's going into hospitals and putting that back into the community and trying to keep people in the community versus hospitals because they're very expensive. So what causes healthcare costs to escalate? So the total healthcare costs are a function of the price and the utilization rates of healthcare services. So cost equals price times utilization. Price is the rate that healthcare providers set for the services they deliver, such as the hospital rate or physician fees, as well as the unit prices of medications and supplies. So this would be the price that we set as nurses to work in a hospital. So the College of Nurses and our union will work together and they come up with a pay scale that nurses are paid. Utilization refers to the quantity or volume of services provided, such as the number of diagnostic tests undertaken or the number of patient visits. Price inflation in medications and supplies, as well as growing labor costs, are leading contributors to increasing price for healthcare services. In recent decades, the rise in healthcare prices has dramatically outpaced general inflation. And so what you'll see is a number of hospitals will come together and they will group purchase certain things. Maybe they'll group purchase certain supplies, or maybe they will hire one podiatrist that will work amongst 3 hospitals. So they will work together to get group purchasing for certain supplies, medications, maybe services. And that's why you hear about hospitals outsourcing certain things to get a better price. So this just gives you a little bit of an understanding of this whole healthcare costs and price times utilization. So we've got if something costs $1 and is utilized at 100%, so then the total cost will be $100 and there'll be no change. But the second line, you see that there's been an increase in inflation. So now we've increased it to $1.08 is the price for a certain thing. We utilize it at 100%. So now it's going to cost $108. So that's a plus 8. And then the other examples are given here. The third line down is maybe more procedures need to be done. And so because of inflation, it's $108, but now we're doing 5 more procedures than what we budgeted for. So now our rate of increase is 13.4%. And then the last one would be maybe we've done 10 more procedures than we should have done from the original cost. And so now we're up to a plus 18.8% change, but we're not getting any more money from the government to cover this. They're only covering the initial cost of the product at $1. So just gives you some idea of inflation and that sometimes it's hard to control for costs. So what causes healthcare costs to escalate? Well, most physicians are not connected to the healthcare system as full employees. Rather, they tend to be independent contractors who drive the utilization of services such as diagnostic tests, procedures, and in-hospital bed stays. And so they're kind of like contractors, and they are largely paid through models that include fee-for-service elements that can provide an incentive for a physician to do and bill more rather than less. And work less. And so the physicians have been hard hit in the last couple of years to really cut back on the number of x-rays that they're ordering, the number of procedures that they're doing, the number of procedures that are required. And so, but we need to know that we can't come down on physicians alone, and they're not directly accountable to all the costs for healthcare services. There's other things that come into play as well. And one of them is the attitudes and behaviors of healthcare consumers. And so we as Canadians feel that we have universal healthcare and we have a right to have anything we want within the healthcare system. And so our attitudes and behaviors as consumers of healthcare also contribute to rising costs. In general, we prefer to be fixed when something goes wrong rather than maybe practice prevention. When we need fixing, expensive high-tech services typically are perceived as the best care. Many of us still perceive that the physician knows best, so we may not seek out any information related to the costs and effectiveness of different healthcare options. When we do seek information, it may not be readily available, accurate, or understandable. And so we are not accustomed to using other less costly healthcare providers such as nurse practitioners if they are accessible. And we don't tend to want to practice prevention. So that's another big piece of it. Other things are healthcare financing. And so, we've talked about the way healthcare is financed in Canada also contributes to rising costs because a large portion of healthcare spending is financed through taxation and not directly by consumers. So we don't directly are paying for it, but we're heavily taxed for it. And so consumers, users of the system, are less aware of the direct costs involved with even something as simple as a visit to the emergency department. And so effectively, there's no direct financial disincentive exists that if we overutilize the emergency department. And then, of course, our changing demographics are huge. With our aging population, they need more healthcare services. The largest number of individuals living right now are our aging population, and so they do consume a lot more money than other populations. So this is just important to understand that as a patient, how are you weighted when you go into the healthcare system, whether it's in a hospital or whether it's community care? Well, there's actually a classification system. It's called the Casemix Groups, and it represents a patient classification system used to group the types of inpatients in a hospital, but also in the outpatient system as well. But I'm going to speak more to the inpatient system. And so Casemix Groups, so CMGs, are assigned after a person is discharged from the hospital, at which time the patient chart is reviewed and coded. And CMGs can either be categorized as typical or atypical, such as long stays. So if you've had a long stay, you're kind of an atypical. And so the CMGs can be a useful source of data for nurse leaders to use in determining the types of services and resources required to care for patients within their portfolio or within their unit. Although the CMGs can help categorize patients' health problems more precisely, the need to understand the level of resources required for those patients is important. And as a result, resource intensity weights, or RIWs, are assigned to each individual, representing the value of resources that each case, so each CMG, is expected to consume, as well as the expected length of stay. So I'm going to refer it to my patient population, which was heart surgery. So typically someone would come in for a heart surgery, so a bypass surgery. They would typically come in the day before, they would go for surgery, they would go to the intensive care unit for 12 hours, and then they would come to the unit for 4 days, and they would go home. And we would price accordingly. So the resource intensity weight for that patient could be, $10,000. Right? And so every nurse manager would budget $10,000. But you can see when you go back and you categorize patients as typical or atypical, you can see that there's outliers of patients that maybe stayed longer or what have you. And so it's important to think about those outliers. So the patient that stayed longer, what can the nurse leaders and nurses do to prevent the longer lengths of stay? So age and other comorbidities also play a factor in the RIW calculation. So maybe this patient that came in has diabetes, maybe they've had a previous stroke. So we know that they're going to be outside the typical RIW. And so, these age and comorbidities are factors that can have a major effect on the resources required to care for different patients with the same diagnosis. So it's just important for you as nurses to understand that. So where does our money come from for healthcare? Well, 70% comes from taxation, so through the province. So obviously anything that you get taxed on in your income tax and the taxes that are taken off when you work. And then 30% comes from the federal government. So a lot is based on the province. So let's dive into that a little bit more. So healthcare in Canada is financed through a mix of public and private funding. So we know we get 30% from the federal government, but with the public sector, it comes in different ways. So the public funding is 70%. Now, we do have a mixture. So of the 70%, where do we get that money from? Well, there's a mixture of third-party plans and private pay situations as well, and they make up about 30%. So, the 70% of healthcare services are public funded, but these public funding don't cover everything. So they cover hospital admissions, emergency department visits, general practitioner visits, and most home and healthcare and public healthcare services such as immunizations and vaccines. But they don't cover everything else. So the rest is covered by a mixture of third-party insurance plans and private pay situations. So private healthcare is regulated and tends to apply to the less acute or non-core rather than basic healthcare services. So the third-party things could be such as dental care, eyewear, physiotherapy, massage therapy, things like that that's not covered under our public health insurance or the public funding. Private health insurance is the second major source of healthcare funding in Canada, and most Canadians, through your institution, have some form of private health insurance to complement their publicly funded basic insurance. And then some costs, if individuals don't have, so this is just explaining what the fully funded is. That public funding is 70%, and this is what it covers, but there's also a 30% that's not covered. So what the difference is between this slide and the previous slide is what I'm trying to show is that, yes, we get 30% from the federal government, and the public, we have to fund 70%. And of that 70%, this is how it's broken down. We use some of the public funding, but there's other pieces that are not publicly funded. So the publicly funded, again, are the hospital admissions, the cost for physicians and things like that, but the other pieces that are not funded. And so there is also people that don't have third-party insurance or private pay situations. They actually can pay out of their pocket as well for certain things. So healthcare, as you will hear throughout your 4 years, is a major public concern, and rapid changes are occurring in an attempt to restrain the costs and improve the health and wellness of Canadians. So there are certain strategies that are shaping the evolving healthcare delivery system, and they include a primary healthcare reform. So kind of thinking about focusing on non-hospital, early treatment of health problems, a big emphasis on prevention to reduce overall costs. The second one is patient-focused funding or activity-based funding. And this is a system whereby an organization is reimbursed at a set price per case based upon the agreed upon outcomes, such as wait time, targets, what have you. And so this is a money that's given to hospitals if they're meeting their targets. And then another part is regionalization. And I'm going to talk a little bit about this because Ontario is kind of heading towards this. So it's an operating model where several health entities are merged into one organizational structure with the intent of reducing overhead and creating efficiencies. And so I'm going to get to that in a second. So with healthcare spending increasing, the concept of bending the cost curve has never been more prevalent. Therefore, most jurisdictions in Canada are exploring new ways of providing services to maximize efficiencies and, most important, to reduce demand. The emphasis on primary health and community care is an attempt to reduce the burden of hospitalizations, particularly for people with multiple chronic illnesses. By reducing the demand at the front door, the need to expand services and build new capital infrastructure is reduced, avoiding costs that otherwise would be borne by taxpayers. Primary healthcare clinics and providers can treat many people for the same cost as a single overnight hospital stay. So again, trying to keep patients out of the hospital and in the community. And again, I want to come back to this regionalization. So regionalization is an organizational structure many provinces have gone to reduce overhead and administrative costs. So when several hospitals and community care services operate under one umbrella, the need for separate support services such as human resources, finance, and procurement of goods and services is reduced, theoretically reducing the system costs. As funders of healthcare demand more value for money, the push to further consolidate back office or overhead functions continue to grow. It is suggested that the goals of regionalization in Canada has not been realized as fully as possible, mostly because physicians and primary care settings are usually not part of these structures. And so it's looking at having this umbrella to ensure that, we can maybe not everyone needs to go to the hospital setting, that they can go to a primary care setting or a community setting, but also reducing the number of human resources that runs this by having everything under one umbrella. And this is where the Ford government has been going with this so-called Ontario Health Super Agency. And so the Doug Ford government is creating a central agency called Ontario Health to oversee the province's $60 billion healthcare system. The super agency will be formed by dissolving our local health networks, which we currently have, which were called the LHINs, and merging their duties with those of 6 provincial health agencies, including Cancer Care Ontario and eHealth Ontario. So again, merging them and reducing the repetition of human resources. So what does the healthcare economic environment mean for nursing practice? Although the healthcare economic environment is ever challenging, nurses must value themselves as healthcare providers and think of their practice with a context of organizational viability and quality of care. To do this, they must add financial thinking to the repertoire of nursing skills and must be mindful that the services they provide add value for patients. Services that add value are of high quality and they affect health outcomes positively and they minimize costs. And so we're going to talk about, in the next sections to come, we're going to talk about thinking or developing financial thinking skills and ways to consider how nursing practice adds values for patients by minimizing costs. Let's look at some cost-conscious nursing practice. The first one is knowing and controlling costs. Understanding what is required for a unit to remain financially sound requires that nurses think about not only the costs associated with individual patients, but more so considering how to control costs to the systems as a whole. As direct caregivers and case managers, nurses are constantly involved in determining the type and quantity of resources used for patients. Resources include supplies, personnel, and time. Nurses need to know what costs they generate by their decisions and actions. They also need to know what items cost and how they are paid for so they can make cost-effective decisions. So an example is if you're hanging a bag of saline for an IV, do you really need that 1 liter bag of saline? Maybe your bag that you're piggybacking into only needs a mainline, maybe a 250 ml saline bag. So just kind of thinking about what are the costs. Understanding that, isolation rooms, do not bring a huge amount of supplies into isolation rooms because they're all going to be thrown out at the end. So just thinking about knowing and controlling costs. The second thing is using time efficiently. So the adage that time is money is fitting in healthcare and refers to both the nurse's time and the patient's time. When nurses are organized and efficient in their care delivery and in scheduling and coordinating patients' care, their organization will save money. Doing as much as possible during each episode of care is particularly important to decrease repeat visits and unnecessary service utilization. Because length of stay is the most important predictor of hospital costs, patients who stay extra days cost the hospital a considerable amount and increase congestion. Decreasing length of stay also makes room for other patients, thereby potentially increasing patient volume and reducing wait times. Nurses can become more efficient and effective by evaluating their major work processes and eliminating areas of redundancy and rework. And so it's all about kind of stepping back and thinking about how you can use working with the nurse leader, nurse manager, and thinking about how could we use our time more efficiently on our unit. Evaluating the cost effectiveness of new technologies. The adoption of new technologies can present dilemmas in managing costs. In the past, if a new piece of equipment was easier to use or benefited the patient in any way, providers were apt to want to use it for everyone, no matter how much more it costs. Now, they may be forced to decide what patients really need the new equipment and which ones will have satisfactory outcomes with the current equipment. And so this is something to think about when you're looking at the cost effectiveness of new technologies. Does everyone need a VAC dressing? That's a very costly dressing, and you'll learn about dressings probably in third or fourth year, but it's a very high-tech dressing. Does everyone need that, or could we go back to our regular dressings and think about a different way we can use our standard dressing? So that's just an example I'm going to give you. The next one is predicting and using nurses' resources efficiently. And so this is something more for the nurse manager. Because healthcare organizations are service institutions, the largest part of their operating budget is labor. For hospitals, nurses are the largest group of employees and account for the most of the labor budget. Staffing, as mentioned, is the major area nurse managers can influence in managing costs. Supply management is the secondary area. To understand why this is so, it is helpful to understand the concepts of fixed and variable costs. So, a total fixed cost in a unit are those costs that do not change as the volume of patients change. In other words, with either a high or a low patient census, expenses related to facility costs such as heat and light, support costs, administrative salaries, and salaries of the minimum number of staff to keep a unit open must be paid. Variable costs are costs that vary in direct proportion to patient volume or acuity. Examples include nursing and direct care staff, supplies, and medications. So this just looking at how can you predict and use your nursing resources more efficiently when you have a low census versus a high census. So something like that. And lastly, using research to evaluate standard nursing practices. Nurses use research to restructure their work to ensure they add value for patients. So it's important to think about the best practice guidelines. Are there practices out there that maybe are more cost effective and efficient than the nursing practices that we're using now? So to be constantly thinking about the research and what's new in the research and what's new with the best practice guidelines. So I'm going to stop here and I'm going to do a small lecture on budget. So just to kind of give you an understanding of what a hospital budget is and how a nursing leader will use a hospital budget.